Good evening, everyone.
Okay, so today we'll try covering acute kidney injury, chronic kidney injury, and nephrotic syndrome. We can do the much we can, and please also contribute. Yeah. So, what can we say about the acute kidney injury, or what do we know?
It's an abrupt decline in renal function, which happens within hours to days. It's very sudden.
Yeah. Anything we know what causes it, or anything? Okay. So, acute kidney injury is it's generally a decrease in the kidney function, and you can it's evident by the changes in the serum creatinine, blood urea, nitrogen, and the urine output. Yeah, and it in if the patients with patients with pre-existing renal impairment, there is a rapid decline in the renal function, and that is why it can be moved from acute to chronic renal failure. And here, when we say that there's an increase in serum creatinine, it's at least 0.3 milligram per deciliter within 48 hours. And the urine output also decreases, and only one of this creatine criteria needs to be met for diagnosis of AKI. So we say there's an increase in serum creatinine of at least 0.3, or a 50% increase in serum creatinine within 7 days, and a urine output of less than 0.5 ml per kg per hour for at least 6 hours. Epidemiology, it's mostly for the hospitalized patients and also for patients who are sick. Pathophysiology, so it can be divided either into pre-renal, intrinsic, or intrarenal, post-renal AKI. So when we say pre-renal, it's going to affect the arteries. Intrarenal is inside, like the Bowman's capsule and all, and post-renal is the ureter, or it's going to affect the ureter or the urethra. Yeah, this is just explaining what I've said. And pre-renal, it's going to be like there's reduced blood flow to the kidney, and it's caused either by hemorrhage, dehydration, GI fluid losses. So early volume restoration can prevent progression and improve recovery because there's no structural damage to the kidney yet. It's yet in the arteries, renal artery. So it can yet be treated. Because of pre-renal acute kidney injury, it can also affect the cardiac output. It can also lead to hypotension and decreased glomerular perfusion and pre-renal AKI. So, NSAIDs also impair the prostaglandin-mediated dilation of the afferent arterioles. So, ACE inhibitors and ARB inhibits the renin pathway. Also, we need to know that the calcineurin inhibitors, cyclosporine and tacrolimus, when given in high doses, can lead to renal vasoconstriction. The intrinsic acute kidney injury is caused by it's caused when it affects the inside the kidney, like the glomerulus, the nephron, the blood vessels, and it can be due to aminoglycosides or contrast agents or amphotericin B, and it can result in ischemic, can cause ischemia. Yeah, so here we have it can decrease the effective extracellular volume. So you can have hypovolemia, which can be characterized by excessive sweating, diarrhea, vomiting, diabetes that can lead to osmotic diuresis, hemorrhage, burns. It will also decrease the cardiac output and can lead to acute myocardial infarction, cardiac failure, hypertension. It can also cause systemic dilation. So that will be like you have septicemia with vascular bed dilation and decreased circulating volume. The patient can have anaphylaxis. And when it alters the renal vascular regulation, we can either have the afferent atrial constriction and the efferent. Now, if it's in the afferent, that we know that is going to bring the blood to the kidney. So you can have sepsis, hypercalcemia, and drugs that can cause this is NSAIDs, amphotericin, cyclosporine. We've mentioned about this. Intrinsic is in most of the cases, it's intrinsic. Post-renal is, I said that is going to affect the urinary outflow. That's the ureter and the urethra. And the causes include benign prostate hypertrophy, pelvic tumors, and precipitation of the renal calculi. Rapid resolution without structural damage to the kidney can occur if the underlying obstruction is corrected. So this is just a summary of pre-renal and pre-renal, intrinsic, and post-renal. So we can see that I think we've mentioned all this. Yeah, we can see that serum urinine and creatinine ratio is more than 20:1 in pre-renal. Intrinsic is 15:1, and post-renal is also 15:1. Another thing to note is that if it's intrinsic, yeah, it's going to affect the glomerulus. So there'll be protein that will be excreted in the urine. So only for that it will be positive, while for pre-renal and post-renal it is negative. The category of acute kidney injury is based on the urine output. So if you're anuric, means that you have less than 50 ml per day. Oliguric is less than 500 ml per day, and non-oliguric is more than 500 ml per day. And the normal urine output is usually 1200 ml per day. And what could be the signs and symptoms? So you can have peripheral edema, weight gain, nausea, vomiting, diarrhea, mental status change, fatigue, shortness of breath, pruritus, volume depletion, weight loss. Note that this is for pre-renal. If it's post-renal, you have anuria altering with polyuria. And colicky abdominal pain radiating from the flank to the groin, that's in the post-renal. Also increased blood pressure, JBD, pulmonary edema, hypotension, and bladder distension. So diagnosis, it's you'll just the gold standard here is like seeing if there's elevated serum creatinine and urea, and those two, and you check their ratios, individual levels plus the ratios. Yeah, so if it's more than 20:1, it's pre-renal. If it's less than 20:1, then it is intrinsic or post-renal. Also, you can do urinalysis, proteinuria, that is mostly in intrinsic. Hematuria or red blood cells is also in the intrinsic. Urinary catheterization is just to rule out there is no urethral obstruction. You can also do renal ultrasound to just see the size, position, and abnormalities of the kidney. So if you have CKD, the kidneys will be smaller. You can also do CT scans to see if there are any kidney stones, and renal angiography to just show the blood flow through the kidney. A narrowing of the vasculature can be seen in conditions such as renal artery stenosis and renal vein thrombosis. Kidney biopsy. Are we together?
Yes.
Am I too fast?
You're good.
Okay. Can someone try or say what we know about the treatment?
You can give loop diuretics. And then I think treatment would depend on on you treat the whatever is like causing, like if it's hyperkalemia or hyperkalemia or hypokalemia, and then that's how you treat for AKI.
Yes. Anything you can recall if there is like we said it's going to affect the if it affects the intrinsic. Oh, sorry, that is chronic. Okay, so we'll look at the treatment. I'll use this chart where you'll see you can give IV therapy or oral therapy depending on the levels of creatine in your body. So if it's 25 to 75 ml, actually if it's less than 25 or 25 to 75, you can give furosemide, bumetadine, and torsemide. It's just that the dose will be changing. So you give a higher dose for the one that has a less creatine clearance, and all of them are given twice a day. For the oral therapy, it's the same. It's just the same. Okay, then you evaluate if the patient has hypovolemia. Then if it is hypovolemia, you discontinue giving diuretics and reassess the volume status. Or you can just reduce the doses. If it's okay, you can just continue the same treatment. But if it is hypervolemia, you double the doses of diuretics and you see if there are any volume changes. If there are no, then you can add a thiazide diuretic or metolazone and hydrochlorothiazide. Yeah, if the hypervolemia is persists, then you consider infusion loop diuretic in the hospitalized patient, or you can do a combination loop diuretic and an albumin in the patient with nephrotic syndrome. We'll look at the nephrotic syndrome in a bit, and you can do dialysis if needed. Okay, what can you give if the patient has hyperkalemia?
Calcium gluconate.
Yes, calcium gluconate is the main treatment.
Insulin.
Yeah. So we give calcium gluconate IV over 10 to 5 to 10 minutes. It's going to help improve the myocardial stability, but has no effect on the serum potassium levels. And you can repeat the dose. Then if it's an emergency, you can even give 50 ml of 50% glucose with 10 units of soluble insulin. And also nebulized salbutamol can be used to lower the potassium. But this is not effective for all patients. And if you have acidosis, it can also lead to hyperkalemia. So it's treated with sodium bicarbonate and dialysis. Sorry? Did someone say something or wants to add on something? Okay. Hypocalcemia, you can vitamin D is activated in the kidneys. Yeah, so it when the renal function is affected, that means there will be not active vitamin D, and that can lead to hypocalcemia. So you can give oral calcium supplements with calcium carbonate. And then for hyperphosphatemia, the kidneys usually excrete phosphate. So, but it rarely requires treatment. But if needed, you can just use a phosphate binding agent to retain the phosphate ions. Example is calcium carbonate or calcium acetate. And the other one is renal replacement therapy. Yeah. That's it for this. Anybody wants to give a summary or say the main points? Okay. So in summary, acute kidney injury is just reduced function of the kidneys, yeah, and it's characterized by changes in the serum creatinine and blood urea nitrogen and the urine output. These are the three main clinical signs. And also it's divided into three categories. Pre-renal, that's going to affect the renal artery and the afferent arterioles. If it's the intrinsic acute kidney injury, it's going to affect the glomerulus, the PCT, the distal tubule, the collecting duct, and all. But the main one is the glomerulus, because if that is affected, that means there'll be increased proteins and other things. And if it's post-renal, it's going to affect the bladder, that's the ureter and the urethra. So that will affect the urine output. Okay. Then the main presentations in pre-renal is that there'll be volume depletion, there'll be renal artery stenosis, the patient can present with cardiac heart failure, hypocalcemia, or if the patient has used NSAIDs. This is going to affect the pre-renal. And then if you do a physical examination, the patient will have hypotension, dehydration, and Here, the patient will present with a negative proteinuria. If it's intrinsic, the patient is going to present with hypotension and nephrotoxins. Example is contrast or antibiotics. And physical examination will just be fever, and it will show positive for proteinuria. And for post-renal, the patient can have kidney stones, BPH, or cancer. Yeah. In physical examination, you'll see a distended bladder or enlarged prostate, and it will show negative for proteinuria. For diagnosis, we said the main thing you check is the metabolic acidosis, blood urea nitrogen to creatinine ratio. You could do urinalysis or renal ultrasound to see the size of the kidney, and kidney biopsy, CT scan. Yeah. And for treatment, we mainly have the loop diuretics. For hypokalemia, we said you give calcium gluconate. For acidosis, we said you could do dialysis or give oral sodium bicarbonate. And for hypocalcemia, we said you give oral calcium supplement. Yes. Should we continue with chronic? Chronic renal failure.
Yes.
Yeah. Hey, why did it stop closing? Can you see now?
No, not yet.
Okay. What can we say about the chronic renal failure or CKD? Anyone? Or just to add on, yeah, for the acute kidney injury, it's like it's for less than 3 months. While for CKD, if you go to see the GFR, it's a constant decrease for over 3 months. That is when you characterize it as chronic kidney disease. Okay. So chronic kidney disease is again yet a severe damage to the kidney, and the kidney function declines over a period of time of several months to years. Yeah, you need to measure the GFR, and this is the formula. I'm not sure if you're supposed to remember the formula of how to calculate. But for creatine clearance, this is the formula. You do 140 minus the age of the patient. You multiply it with the weight, and if it's a female, you multiply it by 0.85, divide it by 72 times the serum creatinine clearance. So we have 5 stages of chronic renal failure. Yeah. So if it's stage 1, the GFR will be more than 90 ml per minute. The patient will have proteinuria or hematuria or structural damage, and the kidney damage is with normal or increased GFR, but other evidence of kidney damages, like the kidney evidence of kidney damage would be proteinuria or hematuria. And if it's 60 to 89 ml per minute, there'll be slight decrease in GFR. Stage 3 is 45 to 59, that's moderate reduction in GFR. 30 to 44 ml is with or without evidence of other kidney diseases. 15 to 29 ml per minute is severe reduction in GFR, and less than 15 we say it's the last stage 5 and kidney failure. So CKD increases with age and it's greater in females. The risk factors of chronic kidney disease, it's associated with an increased risk of developing CKD, but it's not directly proven. So it's they're not modifiable pharmacologic therapy or lifestyle modification. Like you can't do anything about it much. You just treat the underlying conditions. But it worsens with time if you don't take care of it. Yeah. So the factors, susceptible factors could be advanced age, reduced kidney mass, family history of a kidney disease, systemic inflammation, or dyslipidemia. Also, hyperlipidemia. Patients with CKD have a higher prevalence of dyslipidemia, and it decreases in high HDL-C levels. And hyperlipidemia can promote renal injury. So there will be lipid deposition causes the activation of the macrophages and the monocytes at the site, and that will mean that there'll be growth factors that will stimulate cell proliferation and the oxidation of the lipoproteins. Then endothelial dysfunction leads to cell injury and fibrosis in the kidney. Now, if you have DM, hypertension, or glomerulonephritis, it's going to cause CKD. Yeah. Also of an autoimmune disease, polycystic kidney disease, drug toxicity, urinary tract abnormalities. How does CKD progress? Like if you have hypoglycemia, you don't, there's poor control of blood glucose, hypertension, proteinuria, tobacco smoking. So if there's so many factors that affect, then obviously damage to the kidney, and it will lead to the loss of the nephron mass, which means that there'll be hypertrophy and there'll be changes in the glomerular filtration. So as time progresses, the glomerular capillary pressure is increased, and it's mediated by angiotensin II, which is a potent vasoconstrictor for both the afferent and the efferent. Yeah. And it will increase the pressure in the glomerular capillaries. When that pressure increases, it's going to allow proteins to be filtered through the glomerulus, and filtered the filtered proteins are reabsorbed in the renal tubule, which will activate the tubular cells to produce inflammatory and vasoactive cytokines. and will lead to interstitial damage and scarring of these renal tubules. And eventually you'll lose the nephron mass. Yeah, this is just a summary. So the clinical manifestation. So if it's stage 1 and 2, it is asymptomatic, but stage 3 and 4 are more, you can see the symptoms in the patient. So what are those symptoms? Just like acute kidney injury, they'll have the confusion, seizure, coma. It will affect the kidneys, which will cause polyuria. We saw in acute kidney injury, it was oliguria. Yeah. Hormonal infertility, loss of libido, amenorrhea, impotence, osteomalacia, osteosclerosis, hyperparathyroidism. This is all because we know that calcium, there is hypercalcemia. Hyper. Also anemia because we know that the kidney produces the hormone erythropoietin, which is used for blood. Yeah, I mean red blood cells, and that will decrease. So that it will lead to anemia and platelet abnormalities. We have hypertension, heart failure, pericarditis, GI, you'll have nausea, vomiting, and peripheral neuropathy. Yeah. You can also see uremic frost. This is the white, like your skin. I don't know how to put it. It just becomes white. It's like it looks like. Uh, how do you? I don't know how to describe this, but this is how it looks like. Factors that contribute to the pathogenesis of anemia is there'll be the red blood cells will survive for a shorter period of time because of the marrow suppression. So it will have iron or folate deficiency. Yeah, and the principal cause results from the damage of peritubular cells, leading to inadequate secretion of erythropoietin. And hypoparathyroidism can reduce erythropoiesis by damaging the bone marrow, so worsens CKD. Yeah, this we've mentioned. Yeah, I want to say. Okay. Here it's about the vitamin D that is getting activated. It is going to, but it will not be activated. So it's going to reduce the mineralization of the bone, which is osteomalacia, and it will decrease the phosphate excretion. So that means there'll be hypophosphatemia and also hypocalcemia and lead to osteosclerosis. What tests can you do for diagnosis from this? What can you say? What tests are done?
Like complete blood count, the electrolyte panel, things like that.
Yeah. Yes. Anything else? The common one is GFR. Yeah. You can Oh, by the way, that uremic frost is because of the crystalline urea. Okay, the patient will also have edema, right? So you can see that when these patients have edema, yeah, they have a fishy smell, and it's known as uremic phoeta. So you can have do the lab tests, see the blood urea urea nitrogen and serum creatinine. They'll be increased and decreased GFR. Yeah, you can. She's talked about the CBCs, which will show the hemoglobin levels. The urine will show positive for albumin and protein. There'll be increase in parathyroid hormone, decreased vitamin D levels. That will be for stage 4 and 5. Okay, what can be the non-pharmacological treatment? Anyone?
Sodium and potassium restriction.
Yes, sodium and potassium restriction. Phosphate restriction also. Yeah. Then also if the patient is smoking. And for pharmacological, you can administer insulin, yeah, because of the patient is, if the patient is diabetic. And to control the blood pressure, you can either give ACE or ARB inhibitors like enalapril losartan. I'll just use this slide. So if the blood pressure is greater than 130 to 80 milligrams of mercury, the step 1 is you start with ACE inhibitors or ARB, then you recheck the serum creatinine potassium levels. If it's not reached the goal, you add a diuretic. If it's still not at the goal, you can add a calcium channel blocker. And if it's yet not reached, then the baseline is you lower the dose, add a lower dose of beta blocker or an alpha blocker. But the use of beta blocker and this CCB is avoided in elders. Or if the pulse rate is less than, the baseline pulse is less than 84, you can add a calcium channel blocker. Yeah, and if it's not yet reached the goal, you can add a long-acting alpha blocker. Then the management of complications of CKD. The management of we'll look at the management of impaired sodium and water hemostasis, impaired potassium hemostasis, anemia, secondary hypothyroidism, and renal metabolic acidosis, uremic bleeding, and pruritus. So to start with the impaired sodium and water hemostasis, it's the sodium and water balance are regulated by the kidney, right? So there'll be a reduction in the nephron mass, and subsequent reabsorption of sodium and water will lead to edema. And it's usually seen in patients with stage 3. So the symptoms are nocturia, edema, cardiovascular like there'll be worsening of the hypertension. There'll be change in the urine volume. So the lab test is increased blood pressure, sodium levels are within the normal range. So the treatment for it is you just give a diuretic, like loop diuretic. I used to increase sodium and water retention, excretion. I mean, you can either also give thiazide diuretics, like hydrochlorothiazide, and you just evaluate the edema and the fluid. So if the patient has impaired potassium hemostasis, then that is hyperkalemia, and not going to do much on it, but just it's again the same, just reduce the intake, and you can give calcium gluconate. Yeah. Or sodium polystyrene sulfonate can also be given. Also you can give loop diuretics and fludrocortisone. Then for anemia, and we know about anemia. Yes, so the treatment is just going to be iron supplement. You give iron supplement as the first line. And if you're giving it oral, make sure that the patient is not receiving hemodialysis. Yeah. Also, you can give erythropoietin stimulating agents such as epoetin alpha or darbepoetin to treat it. This will also increase the blood pressure. Yeah. This is the algorithm for anemia. So you evaluate the iron indices. Then if the ferritin is less than 100, you give IV iron and reevaluate it. If the ferritin is between 100 to 500, you can give IV iron as well, and give oral iron for 1 to 3 months later on. If ferritin is more than 500, do not give any additional iron. But if it's affecting the hemoglobin, you can just monitor the iron status at least every 3 months. If it increases, I'm lost here. Oh yeah, if the hemoglobin is less than 10, you can do dialysis, and you just monitor the patient. For hypoparathyroid, for
I have a
parathyroid,
question.
yeah,
Why is iron not given when there's an ongoing infection?
it is an ongoing
Infection.
infection. I don't
Yeah.
know. I don't know. Maybe somebody else can.
Iran, I think why iron not given during infection is like the ferritin levels is high, is elevated during infection. So regardless of the body status of anemia, um, iron will not help in this case. It will lead to an anaphylactic reaction, I think. I don't know. Maybe. In Google, it's saying inflammation triggers a process of withdrawing free iron from invading pathogens. So it's not advised to be given during an infection because it triggers the process of withdrawing free ions from invading pathogens. It's also saying it can be detrimental to the host by promoting pathogen growth and predisposes patients to infection.
So basically, it would help the growth of the pathogens.
Yeah.
Okay. Thank you.
Okay, for hyperparathyroidism, for non-pharmacological treatment, you have that you reduce the diet. Yeah, reduce taking meat, milk, and all. You can do hemodialysis and also restriction of aluminum exposure, such as antacids, should be avoided, especially in patients with CKD stage 4. You can do parathyroidectomy as the last treatment if nothing works out. You can use phosphate binding agents such as calcium-based phosphate binders like calcium carbonate, calcium citrate but calcium citrate is not used as a binding agent because the citrate salt can increase the A1 absorption. Yeah, and the side effect here is constipation and hypocalcemia. Savalomar hydrochloride and lanthanum carbonate, they do not contain calcium, magnesium, or aluminum, but they are useful in patients with hyperphosphatemia who have high levels of calcium levels. Yeah. The adverse side effect is nausea, constipation, and diarrhea. And the benefit of this is it reduces the LDL-C by up to 30% and increases HDL levels. You have others like magnesium carbonate, magnesium hydroxide, vitamin D therapy. Is useful when there is less levels of phosphorus and does not sufficiently reduce the parathyroid levels. So we know calcitriol is active form of vitamin D, and the effects are mediated by upregulation of vitamin D receptors in the parathyroid gland. And vitamin D receptor upregulation occurs in the intestines, so it will increase the calcium and phosphorus absorption, and this means that it will also increase the risk of hypercalcemia and hyperphosphatemia. Pericalcitonin, it has a less effect of on the vitamin D receptors in the intestines. So it's mostly useful in patients with elevated calcium products. You can use doxycalciferol for hyper and hypercalcemia and hyperphosphatemia. Calcimimetics like cinacalcate, it increases the sensitivity of receptors on the parathyroid gland to serum calcium levels to reduce the parathyroid secretion, and it's more benefited if the patient has an increased calcium parathyroid product with high PTH levels, and who cannot use the vitamin D therapy. You can do the patient monitoring. You should monitor the patient for phosphate binding agents, and vitamin D therapy. Monitor the if you are giving the patient phosphate binding agents, then you monitor the calcium and phosphorus levels regularly. If the patient is on vitamin D therapy, you monitor the parathyroid levels, and if the patient is on calcate, you monitor the serum calcium and phosphorus levels. If the patient has metabolic acidosis, we know the kidney plays a big role in maintaining that acid-base balance. Yeah. So if we saw in the morning that the carbonate is freely filtered through the glomerulus, yeah, and hydrogen ions are generated during metabolism of ingested food and are excreted at the same time by the kidney. So if the positive hydrogen balance leads to metabolic acidosis, it's going to decline the kidney functions. It's going to produce more of ammonia, and production of ammonia is going to increase, which will compensate. That will decrease the hydrogen ions. So if you have metabolic acidosis, the GFR is going to reduce to 20 to 30 ml per minute, that is stage 4. And it will also increase the protein catabolism and decrease the albumin synthesis. The main management is giving plasma bicarbonate concentration, and also use sodium bicarbonate or sodium citrate. Once the dialysis starts, you can give oral or IV bicarbonate, is not really required. Yeah, once the carbonate levels have been normalized, you give, after normalization, a maintenance regimen of bicarbonate of 12 to 20 milliequivalents per day is divided and can be given. Sodium citrate. Citrate is rapidly metabolized to bicarbonate, and patients who are not able to tolerate this, since it does not produce the blotting associated with sodium bicarbonate therapy, it will promote the aluminum absorption. So should not be taking in, like the antacids should not be given here. You monitor the serum electrolytes and ABGs. Uremic bleeding. we know just a minute. I didn't understand this here, yeah. So I don't know if somebody can take us through the uremic bleeding. I am not sure of things after this here. So I don't know if somebody can take us through or what we can do for this.
Just go back to that slide for uremic bleeding. Yeah, so uremic bleeding, like it's just, this slide is just basically saying that it increases the levels of nitric oxide, and we know that nitric oxide is it inhibits platelet aggregation, and it also has vasodilatory effects. So because of this urea, if there is no platelet aggregation, then there will be increased risk of bleeding because of the urea. So for the treatment for that, non-pharmacological would be dialysis or hemodialysis, which now removes this urea because it's a toxin. And then pharmacological, you have chiroprecipitate, just go down, which it just contains like this fibrinogen and this VWF, which now helps with platelet aggregation or basically the coagulation pathway, so that bleeding is reduced. And then desmopressin is also is a drug that increases the levels of VWF, so there'll be platelet aggregation and less bleeding. And just go to conjugated estrogen. I'm not sure how this exactly works, but it just reduces bleeding time. So I guess it affects some of the clotting factors. I guess I'm not too sure about the conjugated estrogen. Yeah, I think that's it for uremic bleeding. Oh, here there is just up. Okay, yeah. So conjugated estrogen again, because we know that urea causes generation of nitric oxide, but with the conjugated estrogens, it will decrease the generation of nitric oxide, which now leads to increased platelet aggregation and decreased bleeding. So they just reduce L-arginine, which is now a precursor of nitric oxide. Yeah, pruritus is it skin related? Yeah, think skin related. Just go down. Yeah, so over here it's just that we have all these toxins that are not getting out of the body. So all this can accumulate in your skin, such as vitamin A, histamine also. And then just go down. Yeah, so even for the management, you go for dialysis to remove all these toxins from the blood so that they don't accumulate. Then pharmacological, because we know that histamines are one of the causes for pruritus, so you can give antihistamine. And then for cholestyramine, I'm not too sure, but I think it there's a mechanism for that. Just a minute. Yeah, for this cholestyramine, it's a bile acid sequestrant. So it usually interferes with fat soluble vitamins like vitamin A. So again, we know that vitamin A was the one that can accumulate in the skin, causing pruritus. Yeah, and then renal replacement therapy. Yeah, I think that's it. And renal transplant as the last treatment for long-term survival.
For hemodialysis, we can just look at the advantages that it will have a higher solute clearance and allow intermittent treatment. The disadvantage is like it requires multiple visits. The patient may also feel weak after hemodialysis, and it also requires months before patient adjusts to hemodialysis, and his vascular access is frequently associated with infection and thrombosis. Uh, the complication of hemodialysis, it can lead to hypotension, myalgia, thrombosis, risk of infections. For vitamin replacement, water-soluble vitamins are removed by hemodialysis, and that will contribute to malnutrition and vitamin deficiency syndromes. So the vitamins that may require replacement are like vitamin C, vitamin B1, biotin, folic acid, riboflavin, and pyridoxine vitamin K. Yeah, that's it for CKD. Okay, nephrotic syndrome is not much. It's very simple and direct. So for nephrotic syndrome, it's basically the loss of uh, proteins in the urine. It can loss of protein in the urine, especially albumin, which can lead to hypoalbuminemia and hyperlipidemia and edema. And epidemiology, it's most common in adults, but it can affect any age group. Yeah. Also, children have, but that's a specific type of nephrotic syndrome we'll look at. So it's going to affect the primary is going to affect the glomerulus, and it can be if the patient can have other diseases like SLE, diabetes mellitus, amyloidosis, or preeclampsia. So the primary causes of this nephrotic syndrome can be different. So for focal segmental glomerulus, it's more common primary cause of nephrotic syndromes, and it occurs because there's a scar in the glomeruli. Yeah. So this focal segmental glomerulosclerosis basically means that only a few glomeruli cells are affected, not the entire. And it's most commonly in adults, and the disease is severe, and the prognosis is not good. The blood pressure for patients with focal segmental glomerulosclerosis is high, so they have hypertension. There'll be loss of protein in the urine, definitely. So in the kidney, we have this thing called podocytes. Yeah. Now, if the podocyte is affected, that means it's going to be the minimal change disease. For the etiology for this focal segmental glomerulosclerosis is it can be due to HIV or 5B19, and if the patient takes heroin. The treatment for this is mostly steroids. Membranous nephropathy, it's when the membranes of the glomeruli become thick, and also this occurs mostly in adults, or it can be due to hereditary minimal change disease. This one is most commonly present in the children, and the disease is mild, but the prognosis is good because it's going to respond to steroids. And it can be associated with Hodgkin's disease. Yeah, I was talking about the podocytes. So this podocytes, I don't know if I can draw. You draw. So how do you draw on this thing? Okay, so these podocytes are like their cells. So these cells become flat. It doesn't have a big change. It doesn't affect much of the glomerulus. That is why it's called the minimal change disease. Or the secondary causes of nephrotic syndrome is viral infections, paraproteinemia, preeclampsia, DKD. I've talked about this. So the pathophysiology is the glomerular membrane is going to be damaged. So that means it's going to allow the proteins to pass through. Yeah. And normally we know that proteins cannot pass through the glomerulus because of the size and that the fact that they are negatively charged. And also the glomerular membrane is negatively charged. So they are repelled. Yeah. And that is why they can't pass through the glomerular. Yeah. This will increase the proteinuria and hypoproteinemia. Those are the main keys. So if it's hypoproteinemia, that will mean there's increased urinary loss of albumin, and there'll be increased rate of catabolism of filtered albumin of paroxysmal tubular cells. And the compensatory increases in hepatic synthesis of albumin to replenish the protein loss. And it's probably because of malnutrition. Edema formation driven by the reduced plasma oncotic pressure is secondary to hypoalbuminia. So for this, we just yeah, we know when there's increased loss of protein in the urine, it will decrease the protein in the blood. Yeah, and that means it's going to decrease the oncotic pressure but increase the hydrostatic pressure. So that means there will be more fluid escape from the vessels to the interstitial space, and that's going to increase the fluid in the interstitial fluid and lead to edema. The reduced plasma oncotic pressure leads to hypoalbuminemia. Yes. Hyperlipidemia in nephrotic syndrome is characterized by high levels of cholesterol, VLDL, and LDL concentrations. So what happens in the nephrotic syndrome? Hypoalbuminemia will reduce the intravascular oncotic pressure. It's going to reduce the fluid in the interstitial space, and that is going to reduce the plasma volume. So there'll be increased aldosterone in secretion, and there'll be salt and water retention. That's why edema. Or it's going to increase the albumin production and lipoprotein synthesis. That's why you'll have them a high serum triglycerides, and it cause lipiduria. So the main clinical manifestations are swelling of the face, hypoalbuminemia, edema, hyperlipidemia, abdominal distension. Hypercoagulability is caused by renal losses of protein, protein C and S, and antithrombin. Yeah. There's also increased susceptibility to infections because IgG is also going to be excreted in the urine. Vitamin D deficiency and secondary hyperparathyroidism. How do you do the diagnosis? Basically, you do urine analysis, serum albumin, hyperlipidemia, general edema, and renal biopsy. The treatment is not really there, but you can give things like you can advise the patient to reduce the intake of sodium, protein, yeah, and stop smoking. You can give diuretics, but the treatment is there, but it's not like it's going to resolve the issue. Yeah. So you can give diuretics, antiproteinuria agents, NSAIDs, statins, anticoagulants, and corticosteroids. So for diuretics, you can give thiazide diuretics or metazolone, or furosemide is the first line. Yeah. It's just to relieve the edema. And for antiproteinuria agents, the dietary protein, you should restrict the patient to take that. And ACE inhibitors is associated with the fall in filtration fraction, suggesting there'll be a reduction in the pressure. So you can give patient ACE inhibitors and ARBs. NSAIDs, indomethacin, and meclofenamate, because proteinuria, it's going to reduce proteinuria through prostaglandin inhibition, and that's going to decrease the GFR. You can combine it with the ACE inhibitor treatment to decrease proteinuria. Statins is mainly for hyperlipidemia. Anticoagulants is because to prevent renal vein thrombosis, pulmonary emboli, or embolic events. It's usually given, it's sometimes given as prophylaxis to some patients. And those anticoagulants, you either give warfarin or low molecular weight heparin. Yeah, and corticosteroids is mostly used for children, especially for the minimal change glomerular nephropathy, you give prednisolone, and you can give immunosuppressive medications other than steroids, usually reserved for patients who are resistant to steroids. So you can give cyclophosphamide that may benefit patients, or cyclosporine. And for infection treatment, patients who have with nephrotic syndrome, like they have high chances of infection, yeah, because of low IgG. So you can give them pneumococcal vaccine. And yeah, that's it. Any questions? Are we together? Yeah, that's it from my side. Are there any questions?
Shrina, for the, what was the explanation for the hyperlipidemia or hypertriglyceridemia in nephrotic syndrome?
Sorry?
Why, okay, what was the mechanism behind hyperlipidemia in nephrotic syndrome?
Oh, you see, when you have nephrotic syndrome, yeah, you'll have hypoproteinemia. So that
Yeah.
hypoproteinemia is either because of albumin that is going to decrease the osmotic pressure leading to edema. If it's lipoproteins, it's going to increase the lipid formation by the liver.
Okay.
Yeah, and if it's immunoglobulins like IgG is going to increase the risk of infections. And the hypoproteinemia is, if it's because of antithrombin 3, it's going to lead to increase in thrombosis.
Okay. Santi. That
I
was
can
my only
just share a
question.
picture which is easier. I'll just share it on the group.
That's perfect.
It's a simple reason. It summarizes the nephrotic syndrome and why hypoproteinemia occurs. Anyone can do addition, or if something was not clear. I think that's it. Or anyone wants to add or anything, or we can meet at 8 later. Thank you, everyone.
Thank you.